Are you an orthotist and ever face this critical problem? The orthosis looks perfect until the patient walks with it. It shifts, hurts and stops working the way you designed it. Today we'll break down this phenomenon in detail and learn how to correctly place orthotic joints in order to avoid this critical mistake. Why is it so important to exactly match the joint center of your orthosis with the anatomical joint you are treating? Let's take this KFO. Here we have the K-force pivot point at the knee, with the matching path the leg will take while flexing. And here you can see the anatomical pivot point of the patient's knee. The K-force pivot point is not directly mounted on it, but is placed too high. Can you see what the unwanted effect is? They take different paths while flexing. And this causes the part of the KFO that is more loose, either the upper shell or the lower shell, to tilt and push in certain directions. But when does the orthosis shell actually shift in which direction? Let's break that down. You place the K-force pivot point too much posteriorly. This means the AFO part will shift to the distal and ventral side while flexing. And the other way around? You guessed it, the complete opposite. It shifts to the proximal and dorsal side. The same principle is true for a knee pivot point that is too far distal or proximal. The lower shell shifts and causes shearing forces at the knee and can distract or compress it. Now pause for a moment and think about patients where this is the last thing that we want. For example, patients with arthrosis, knee pain, osteoporosis, chronic pain and many more. In all of these cases, joint migration and shear forces are not just minor issues. They directly worsen symptoms and compromise the whole treatment. And it doesn't stop there. What happens when the K-force pivot point isn't just misplaced front to back or up and down, but aligned diagonally? That's where things get really problematic. The shifting directions from every component add or subtract, in which we get a very strong shift in just one direction. And this is true for all four directions. So please be very careful here, especially in patients with ligament trauma and unstable knees. This is the exact thing we want to avoid here. But now you know, when you see a strong movement of the orthosis on the patient while flexion or extension, take this as a clue and closely check the joint center. But what about shearing forces at the ankle joint? A joint misplacement lets the orthosis tilt and shift at the same time. Shifting movement at this level means that the whole orthosis is moving up and down. And I think you guessed it, the whole knee pivot point moves again. Then we are multiplying our problems, which can lead to pain, discomfort and potential damage at joints, tissue or ligaments. So how do we avoid the shifting in our orthotics? Step 1. Know the joint you are treating really well. We have different kinds of joints in our body, all of which allow different kinds of movements in different planes. The hinge joint, for example, has one defined axis, allows for two movements in one plane. Think of the interphalangeal joints in your fingers, for example. The axis goes exactly through the middle of the joint. No surprises. So this means the human knee is a hinge joint, right? Right? Wrong. It is a modified hinge joint. While flexing, the femur rotates and slides forward at the same time. This makes finding the center of rotation much more difficult. In fact, so difficult that all of these studies did exactly that, trying to find out the best center of rotation for the human knee. So they came up with a compromise axis. And this is the one of the most popular methods, the knee pivot point according to Neathart. So, for a human grown-up, this means measure the anterior-posterior distance of the knee. Take 60% and go the distance to the dorsal side. Look for the knee joint space and go 2 centimeters up. At the connection of these 2 points, you have your optimal compromise knee pivot point, with the least amount of shearing forces for your KFO. How do we find the joint center of the ankle joint? This is more complex than it sounds. Let me correct that. Ankle joints. Yes. 2 ankle joints, the upper one and the lower one, all of which have different axes and movement directions. The upper ankle joint allows for plantar and dorsiflexion, and this is how you can find the axis on your model or on the patient. You simply find the lateral malleolus tip, then you got your height. The rotation of the axis depends on the rotation of the foot of the patient. Physiological are around 5 to 7 degrees. The mechanical axis should therefore be perpendicular to the direction of walking and parallel to the knee joint axis. The lower ankle joint, on the other hand, lets the foot move on a tilted axis for an inversion and eversion movement. These two movements are a combination of 3 types of movements, and they affect all spatial planes. But in the case of the lower ankle joint, this one is very rarely directly covered by an orthotic joint with its own axis. So please remember, when you are using a mechanical joint with a predefined axis, make completely sure to meet the anatomical joint as best as you can and study it beforehand. Otherwise the patient could suffer from negative consequences, which we want to avoid completely. Do you want to improve your prosthetic knowledge? Click right here and learn how monocentric prosthetic knees really work. What do you want to learn next? Please write your opinion down right here at the comments. And see you next time at Got It.